afternoon, ladies and gentlemen. Welcome back after lunch break. And we have again live cases. Again, 2 from ICAM and 2 from Homolka and 1 from Austin. So we have 5 cases. So busy agenda. So let's start. So, okay. Let's start with Homolka Hospital. They have a prepared case.
So, good afternoon, ladies and gentlemen. Our first patient after lunch. We are presenting 78 years old male with persistent atrial fibrillation diagnosed firstly in 2014. And that year, the patient underwent cryo PVI, pulmonary vein isolation. But next year, in 2015, he underwent several electrocardioversions because of recurrence of the arrhythmia. Last year, in 2022, he underwent the complex reablation by pulse field energy using Farawave catheter, where we did re-isolation of the pulmonary veins, a newly we did box lesions, mitral isthmus, and CT isthmus. At the beginning of this year, we documented recurrence of atrial tachycardia. The patient has normal ejection fraction, dilated left atrium, and mild mitral and tricuspid regurgitation. He chronically used amiodarone and anticoagulation with dabigatran and other drugs against another possibilities. And here on this picture, it is current atrial tachycardia, which is ablated right now, and colleagues will show the procedure. Thank you very much.
Okay, thank you for the introduction.
Hello. Okay, do you hear us?
Yes.
So from Homolka again, let me introduce Jose Merino coming to us to map this atrial tachycardia already showed. So you can maybe see on Pruka, it's ongoing here, about 350 a cycle, 3 to 1, 2 to 1, about the changing. So Jose, if you want to describe now the preparing the case.
Thank you. We have started with this catheter setting. As you see, we have a decapolar catheter in the CS. We have a 8-degree catheter in the left atrial appendage. The ablation catheter is somewhere. In the left inferior pulmonary vein. And then we have a screwing catheter, screw in the septum. This is our standard in these cases because it provides a very stable spatial and timing reference for your map. Then what we have done so far is perform a quick anatomical map and at the same time an activation map. We can see also voltage. Can you go once to voltage? Yeah. So the atria appears to be quite diseased, especially in the posterior wall. The pulmonary veins appear to be still disconnected. The left were disconnected in the previous procedure, but the right were reconnected. But now they appear to be done. So congratulations to our prac team because they did a perfect job. Now, going back to the left atrial body, it appears to be a quite large atrium with some low voltage areas, especially in the posterior wall and the anterior wall. Then if you look at the activation map, and maybe we can start from the anterior part. Can you start? You see this red color, and there is an activation front going and down from the septum, from this red color, rotating around the right pulmonary veins. Then it goes there to the inferior wall. And then in the posterior wall, interestingly, there are some residual electrons tagged in yellow that you shouldn't expect that color. You should expect that after CN, it will be purple or white, but maybe these colors are missing within the scar. But what I was not expecting to see is that the yellow is followed by by orange. So in the posterior wall, this part at least appears to be descending, okay? And so there is a collision at least in the inferior part of in the right part of the inferior line. So this appears to be blocked, and there is collision of the two. Okay, if we go rotating around, you see that there is green. There was an area of interesting signals with this color that is not matching this orange one with what we were expecting. Maybe we can show in the Bruca the signals there. So they were quite fragmented. So we really don't know if they are related to the circuit or are just fragmenting signals due to the previous applications. So if you can go in, so it appears that everything is rotating around the marginal annulus, but then this green color, up, cranial view, ends there. So still you have some cyan, but the blue, the violet, and the white color are missing. So the question here is whether this is a perimetral flutter, in this case counterclockwise, with some missing colors, maybe because it goes epicardial or maybe close to the ridge. Maybe there are some areas of slow conduction, or whether this is a right pulmonary vein flutter with also, can you go back to the posterior wall? With some, there, with some missing colors, because still there are some areas, you see that there is a blue there, so maybe the slow conduction area is there. And I think that this flutter should have a slow conducting area because the cycle length is 340, so it's quite slow. So,
can we see a signal from this yellow area on posterior wall?
Yes.
My question is also, did you try any entrainment? Because that would be obviously ultimate proof that it's a playing role. It doesn't look like perimitral based on recording from coronary sinus.
Yeah, it's a very good observation, because the first question in reality should be, is this a true, before doing anything, is this a left flutter or it could be a right flutter still? Although this ECG, it doesn't look like a right flutter, but the CS activation is quite flat, or even in a D bracket, so it doesn't look like right, and also it's quite odd pattern for a perimetral flutter. I agree, but I don't know. Maybe we can conduct a poll within the audience who will vote for a perimetral flutter. Raise your hands. No one. And who will vote for a right pulmonary vein flutter? So something rotating around the pulmonary veins, right pulmonary veins. No one raised their hands.
You're sleeping.
And who will vote for a small reentry, what we call a mural reentrant flutter?
Hello? Hello?
Can you hear me?
Hello, this is Hiroshi. So even the macro-reentrant circuit around the right side vein is not evident based on the endocardial activation pattern, suggesting maybe epicardial conduction, or the contribution, or some wrong annotation for the timing. So that we have to, differentiate it. So like, Joseph talking about we gotta look at the electrons, each side, purple, yellow, orange, also the in front of left atrial appendage, basal site, some sign of epicardial conduction.
Well, there might be this early activation, which is below the left inferior vein, might be like orifice of vein of Marshall. So there might be epicardial pathway, but so I probably would do now entrainment, or at least if you can show us maybe this signal from HD grid from that posterior wall area.
We will do that.
It might be
We will
great.
do that.
And we don't see very nicely the signals on the screen because it's very dark. I don't know why you have these dark colors like violet.
Tam trošku
Can we have some yellow or some more nice colors, because it's very hard to see
Yeah, we go for
on
white
the
color.
screen
Okay.
here.
Can you, in the meantime, go to the posterior wall view? In terms of what you said, Hiroshi, about incorrect annotation, I think that most of the points are properly annotated because you see that the colors are quite consistent. The only part that are inconsistent are the orange small dot at the ostium of the ostia of the left pulmonary veins and this posterior wall aspect. But apart from the others, everything is quite consistent. We can also show you, we perform entrainment because we were starting to entrain when you connected. Here you see the signals of this area.
But it was now like dissociate, or is it? No, it's just.
Can you repeat a little bit the map?
Okay,
Center the map?
there is
Yeah.
no contact, just intermittent contact. It's really hard to see, but now it's better with this white color. It's better.
The contact, I think, is quite good because if you see the grid is tilted. It's quite tilted, so it's completely
So
in contact
do you
with the
plan to
surface.
use entrainment?
Yeah, we have already done one from the appendix. Maybe you can show it, the last entrainment that we did. The problem with is, okay, here you see, can you center this blue dot on the map? It was plus 120.
Okay,
So
in appendage.
from the appendix, it looks quite long. One of the potential problems that we are going to face, if you go back to the voltage map, is that there are huge areas of low voltage. So this will create some problems in order to capture.
But that's
not only
after
capture-
previous ablation. I understand that it was a complex pulse field in
Careful,
the whole
because you are going to
posterior
lose
wall
the-
and mitral isthmus. So
You are going to
no
lose the-
surprise that there is low voltage because that was heavily ablated.
Yeah.
I think that you have moved it.
So also this, like we discussed in the before lunch, PFA can produce a transient conduction block, right? I'm sorry, but this is an example. Conduction came back later.
Well, we don't know yet.
Yeah, okay, that's fine.
Yeah.
So what is the plan now?
Yeah, it's...
There's
yeah.
some shifting now.
Yeah. Let's see if it, no, but yeah, let's see. Okay, so the idea is now to perform some entrainment to try to clarify the mechanism. And what we usually do is color code these entrainment values into the map, because if you perform more than 4, then it's quite difficult to remember them. So it makes much more clear the situation if you color code this. Okay, so can you show me the signals from the ablation catheter now? Maybe we can entrain from there. This is the lateral wall. So we are able to entrain, go up to 25 milliamps, because otherwise, and then use 100 speed.
Ten
Because
ablační
otherwise-
je nějaký oranžády, něco tam, teď to svítí, ten ablační, aspoň tě vidět, ty barvy. Nemůžou být všechno bílý, a ten ablační aspoň tě ne,
Can you
ablační
paste?
udělají jinou barvu. Ale prostě tam nepoznáš to. Jako,
Now this is entrain. No,
jestli právo,
no. It didn't work. Yeah, please
jako
again.
z gridu udělejte bílý, ale ne z ablační.
Okay, stop. No. It's, what is your card, pacing output, please?
Kolik máte výdej?
It's maximum.
maximum,
Okay.
yeah.
Pace again. This is one potential problem. Okay, stop.
Stop.
No.
It is capturing
Maybe
sometime,
now,
but
maybe now, yes.
you have to stop right.
Yeah, but yeah, I am not sure. Can you measure it?
Oh, it looks
If it's
reasonable.
true, it's plus 30. Plus 30. That is not much. So,
Wait, I'm double click.
but we should double check. Yes, because
Yeah, it's not so bad. It's really,
no, it's quite good. 30 is okay, but
No, this is not bad. Yeah. So let's go to another place.
yeah. No, but we need to double check. So do it again, because if it's properly entrained, the figure should be quite similar, if not the same.
I
Stop,
think
stop,
this
stop.
is untrained.
Stop, stop. Oh,
No. Repeat it.
the previous was difficult. Just waiting.
No, stop. Now.
Okay.
Okay, measure.
No,
Yeah.
more. This is V.
It's quite consistent. So
Yeah,
it
okay,
appears
this
that
is
it's
okay.
okay.
This is okay. Yeah.
So this is against
Je to do
right
dvoustovky,
pulmonary
to
vein
mě
flutter,
přijde do
but
dvoustovky.
I will prefer to do some
Takže
more
dejte ve dvoustovce.
sex. Maybe the inferior wall, because usually the inferior wall is not affected, and we may record some signals there. Yeah, maybe we can capture from here. Try. Okay, stop. Measure, but then it's quite long now.
Yeah.
So this is against perimeter flutter, so it's 120.
Yeah, also the tremendous fusion in a CS activation sequence.
Can you repeat it just to be in the safe side? But however, when you have a long one, in general, it's true. Can you paste it again? Because this is quite important. Okay, I don't know if you give it time, but it's exactly the same. So it's true. So this is against perimeter flutter. So let's go septal, because the posterior wall will be a little bit more tricky, because the voltage is quite low, and also if it's the potential area of interest. Here I have a electron, so let's start here. Yes. So still plus 100, so it's still long. Can you use interpolation of 14, please? Can you center it in order to see the posterior septum? Because I can only see the anterior one. 14, yeah. Yeah. I cannot see the ablation catheter. Yeah. Yeah, this is leave it in RAO, but yeah. Yeah, that's the problem that.
So the entrainment pacing around the mitoanias all long, like plus 100. Is this indicating right atrial tachycardia or something coming from the posterior wall?
For right atrium tachycardia, I would expect the earliest activation coming from the right septum, and this is not the case. It's true that this is not a clean patient in terms that it has some lines and some, but still, I think that the earliest activation is at the roof. So I think that is quite unusual for a right atrial tachycardia. Also, the CS activation is quite against it. Still, what we can do is paste from the skewing catheter. Can you paste from the skewing catheter and see what we get?
Testujeme ty reference.
Okay, stop. It will be similar or maybe slightly shorter. No, yeah, no, it's 130 plus 130. Yeah.
So the
okay. Can you go back to the ablation catheter, please?
100.
Okay, I think I would suggest to go to another lab because they are already waiting. So we saw some initial strategy, and we come back to you. You will tell us more later. Any question from the audience? Any recommendation? What would you do differently? No? Okay, let's go to Ecam.
Okay.
Vědou se tam všichni, že to bylo takhle. Ale to je úplně jedno, takhle.
Dané, už tě slyšíme.
Yeah. All right. Hello from ICAM.
I see that there is a good
Yeah,
mood.
perfect.
That's important.
This is the, we are about to demonstrate the strategy of high power short duration using Q-rod catheter. We are here with Benjamin Berte, of course, and here is also Petr Stojadinovic. We prepared the vascular and left atrial access, and the rest will be in the hands of Benjamin. I would like to introduce patient. Next slide, please. There is also nothing to introduce because there is no disease except of paroxysmal AF, which was diagnosed rather recently, and the patient is athlete, young and rather competitive. So there is no way to treat the disease by anti-arrhythmic drugs, and so the procedure was indicated directly like a first line treatment. And there is nothing on 24 hours Holter monitoring was AF was documented of the duration of more than 4 hours. Echo is normal, no comorbidities as I already mentioned. And next slide, this is EKG showing nothing, sinus with a single ectopic beat or 2 ectopic beats. All right, next slide, please. Maybe that's all. This is what is scheduled. So show how to ablate paroxysmal AF. PV definitely, isolation, maybe CTI. We have seen some short episodes of organization to typical flutter, and the rest will be discussed during the procedure. Benjamin, please.
So thank you, Dan. So we started actually with what we always do. We combine our tools. We have the Dekenov catheter within the CS. We have the Visigo sheet, the steerable sheet that is visible in the mapping system, and we have the Q-dot catheter. Normally we use the bidirectional one, but here we did it with the unidirectional one. We made a voltage map, and of course what we all expected is that the voltage map would be completely normal. We also saw with eyes that we have a left common ostium. We made these blue points are actually what I call a pseudocircle. We always try to look at the signals in the beginning, then to visually know where we want to ablate. And then we started ablation already on the left side. And I asked before the case on a text, I asked my clinical support, do you want to do hybrid or 90 watts everywhere? And she wants to challenge Dr. Nakagawa, so we are doing 90 watts everywhere. We did the left side, it's isolated, first pass isolation. Thank you. So maybe we can see the ablation points on the left side. They're all 6 millimeters interlesion distance. So in the beginning, without AMT3, we used 4 millimeters interlesion distance. But I truly think that that was mainly because of the inaccuracy of the tags. I think if we know something from the 90 watt lesions, it's probably that they are a little bit broader. So it certainly doesn't have anything to do with the interlesion distance. So now I think you want to show these ICE findings with the bubbles that you had, or?
I guess it was not recorded like online because it was like this is not ready for
okay, no problem. So now I would suppose I think we could continue. So as Dan was telling us, we will start with standardized PVI. We did the left side, it was isolated, but now we will continue with the right side. I think we should also do the flutter, and we will check. We did in hybrid mode. We also mapped already the supraventricular extrasystoles. And we clearly have the feeling that they come from the CS ostium or right side. So we will see if it's a safe site, we will ablate that as well. I think we can do that with the Q-dot catheter. So now we continue with the PVI, and then afterwards we will do CTI and mapping of the extra. Okay. So are there some questions?
Doesn't seem to be the case.
So what is really nice is, of course, with the Q-dot
everybody
catheter.
is astonished.
Sorry?
So I see that you look at contact force and you use the index, or you use only a few seconds of application. Okay.
It is 4 seconds everywhere.
Yeah,
So in the
4
beginning we were a
seconds,
bit afraid, but it's 90 watts 4 seconds. It's the standardized Q mode plus mode that we use.
Yeah.
I think index is not applicable for,
Yeah, I know.
for such a short time because
I forgot
the
that we are
formula
dealing
is
with high
yeah.
energy, short duration. Yeah, too many technologies.
But we will use the ablation index for the CTI afterwards. So we will do both because it's interesting to see. You will see with AMT3 that the ablation index is coming really fast. And what is nice, you can clearly see these PV signals on the microelectrodes. So we really, you go a little bit into the vein, you pull back, and then you can have these nice signals.
Do you use this signal from microelectrodes for somehow looking at the lesion?
I use it for all my cases. I don't even look at the macroelectrodes anymore.
Yeah.
So we use smaller tidal volumes around 400, so to make our life easy. You see here, suddenly we have these nice spikes, so we pull back till we see these nice near-field signals to ablate. We have nice heating.
Do you have any experience with high energy, short duration, or high power short duration using conventional irrigated tip catheter? Because some people use...
You mean 50 watts or higher?
Yeah, higher. Well, some people use 70 watts with conventional tip catheter.
We always used 45 watts with the STSF, 50 watts with the Q-dot, but I never used, for example, 50 watts with the STSF catheter. I think there are some studies that it would be more dangerous.
Yep. So you do the circle around the right veins. Yeah?
Yes.
We can see nicely on ice, maybe for those people who are not familiar. You see right superior, when there is a pulmonary artery on the right side. So then you go, you see already a little left inferior vein now. See, it corresponds to the Carto map. So you have some branch of the vein. So it's nice to watch on intracardiac echo what you are doing. So now it's anterior, inferior part of the vein, exactly corresponding on the ice image here with this position on the map.
Turn to right. Again, you see the nice, a bit later signals here on the micros compared to the macro electrodes. So we use Q mode 50 watts for all, we use Q-dot for all our irrigation. The ablations with irrigation, we don't use any other catheter anymore. Turn to the right. Sophie, were you saying something or not? No, it's okay like this. KPA. So we try to aim for 10 to 40 grams.
Je to trošku zakloněný ten ice, ne? Aby tam bylo líp vidět. Yeah.
But you can all see the people that already did QMOD Plus, the accuracy of the tax is so much more precise with AMT3 than before.
The beauty of short duration is that you have no time to displace the catheter, so you can place lesions really one by one like a necklace. You know, there is no need to erase something, it really goes one by one. And you see on ice that it's already close to esophagus, there is esophagus here. Here we are, Here we are. So it very nicely corresponds. No rise of temperature in esophagus.
So we are 38.5 there.
Okay. You see here. It's in close proximity. Usually, in many patients, the esophagus goes like oblique.
I think
first,
contact
so
is almost
touching almost the right
intermittent just
inferior
now,
vein
yeah.
and then
You
going
see
in
on
an
eyes,
oblique
and there are
course
drops
to the
to
left.
almost zero,
It's
maybe.
not perpendicular. Any questions?
So my tags, they are not... Are there questions?
No. I'm just asking
So
if
we
there is
put our
any
tags in
question. No
impedance drop?
question so far.
Oh, sorry, okay. So I always like to put my tags for QMOD and QMOD plus all in impedance. I don't think it makes any sense to put it in ablation index because we have the values.
Okay.
Yeah.
Who is using here in the audience? Who is using Q dot? Just to have an idea. 2, 3, 4, 5, 6, 7, 8. About 10
Turn on.
people? Okay. Who's using diamond temp? The same person? 3? So, okay. Why? Why not so few? It's a similar technology? Okay. You don't need to answer. Any questions you have for operators? So if I understand, your plan is now after isolation you will go to do CTI and then you will map in the osteum because there is
And
a
then we will
negative,
try also to hunt these extra.
yeah, negative P wave in extrasystole, so it comes somewhere from the area of maybe in front of CS osteum or in the CS osteum.
Exactly.
So can we go to another place and come back when you finish your your ablation set?
Perfect.
Benjamin,
Have fun.
yes? Are you okay with that?
Yes?
Okay, great.
Yes,
So
perfect.
we can go to Homolka to the other room. They have also a case of AFib, if I'm not wrong. Using other technologies, so we will see. Preparing. I thought that it's prepared.
Okay, nice. Okay, Peppo. Ciao.
Yeah.
Hi, Peppo. Ciao. Okay, so we have another case. Actually, we have atrial fibrillation patient, again, redo, okay? So redo patient, and we will try to get a different kind of PFA ablation with the system of Galaxy. Actually, Galaxy was the original name. Now it's a little bit different because they changed the name like for galvanized. So it's no Galaxy, but galvanized. So we have 60 years old male on the table, and he got persistent atrial fibrillation diagnosed like 2021. And because of that, we performed 2022, March, practically 1 year ago, RF ablation. So we apply PV isolation, we apply box, anterior line, and café. So actually it was like really persistent, long-standing persistent, a little bit like more persistent than we usually want to. So, but he was clearly like 1 year okay, but he got recurrences and symptomatic, very symptomatic recurrences recently, okay? So clearly like 1 year after the procedure, he got back, and actually it was clearly like atrial fibrillation, not AT atrial fibrillation. No any valve disease, nothing, okay? So what we are using right now for this patient. So we have the galvanized system, which is like original Galaxy, which is generator be connected with with lot of catheters, several catheters. And actually the system is using and can implement the contact force, actually depends on the system we are using for mapping. So actually there are three settings of energy. So the problem is that the application of the pulses are dependent on cycles, so like cardiac cycles. So it's like 3 applications per cycle, and when you apply more amps, then you need to apply more cycles, okay? So less energy means less cycles, so shorter application and longer application. So it's like biphasic, but monopolar. Biphasic, but monopolar. So what is, is this not too much? Oh, it's interesting. Why? It's interesting. Because you can see here the generator. The generator is connected by this switch box or something like switch box, like Centauri Connect, because the name Centauri. So this is like switch box, and it will be connected to this dedicated catheter. But during application, this system switch off the line to the mapping system. So actually you will see in the live that during this pauses, we have any idea where the catheter floating. So there are 3 different main systems applicable for this Galaxy or galvanized generator, which is Scarto, which we'll be using now, Insight and Rhythmia as well. And both, 3 systems, not both, 3 systems are using this contact force catheters. So what is Atul Verma published, which is interesting. So actually he compared, the applications using galvanized system in terms of dedicated pulses and dedicated amplitudes, and compare it with all data comparing RF. And so when you apply 25 amps, then the lesion set, the lesion depth is really satisfied. So actually he proved that with increasing amps, you can really increase the depth of the lesion. The critical thing is how we can assess the heating formation, because well, you need to figure, and we know, and actually Pepa published, or we all speaking about, for example, for a Affera system, we know even with pulse field, we increasing the temperature. But the question is how much we are increasing. So it's clearly proved with this, even Tacticat, when Tacticat was connected to the Galaxy, this galvanized system generator, that it was slight increasing, but actually the temperature was not ablative. Okay, so they clearly prove that it's not critical, and actually that's why we have some system of applications. Then we can really use with thermocool catheter 25 or 22 amps. So increase make a shorter procedure. So we apply on the posterior wall less amps, so like 22. On the anterior wall, actually in the ridges, so and maybe mitral line. So we are using the max amps. So this is some settings of the lesion set. So usually depth depends on what I discussed, depends on the amp. So actually you can get up to 8 millimeters, but actually as well you need to figure the overlap. Okay, the overlap, because it's a spot catheter. Okay, so it's different than Farapulse, it's different than Affera. So actually this is really critical to get settings to overlap. So in terms of this lesion, the core of the lesion, we use the 6 millimeters, like in average. So then I really like to get at least 20% of overlap, means 2-3 millimeters to get here. So then the thing is to create not this, not overlapping lines, but rather the high density. So high density means more overlaps, means more solid lines, okay? So I think that's all for this technology aspect. And let's move to the case. Actually, well, we have Toshi and I'm there as well. And actually, we will show you on the Kato what we did up to now, okay? So we have two or three maps. Actually, we have three maps because coincidentally, what we found. So the patient, as I told you, is after 1 year ago, he was after RF ablation. So PV isolation, box lesion, and that's a catheter, okay? That's it. So we started actually to prove PV isolation. And actually it was clearly visible that, right-sided PVs were reconnected, okay? So we applied this kind of, can you indicate the lesion on the left part of the screen, on the Kato screen? So we set up the lesions on the posterior part of the right inferior, right superior and right up to the right inferior vein. And actually we close up the gap.
RSPB.
Then actually the patient moved, okay? So we really need to, so we got new map, and actually based on the box and all the high density mapping system of Pentanav, so we clearly figure some kind of patchy connection. So actually we really recognize the slightly gaps on the superior and even inferior line of the box, of the original box lesion. Okay? So now Toshi will show you, actually, well, are you ready to get for the inferior line, or we need to show them the principle, okay?
Yes.
So let's go to show them, and I will take the gloves as well. So
yes.
Let's continue, okay?
And let's take a look at the signals at the beginning. So can we see the Pruka review
Please
screen?
show the Pruka from the first tracings, the first map.
Let's click on the LS. This is LSPB and LI. So left veins were isolated after the first RF PB isolation, and then go next. This is a signal in the right superior pulmonary vein. The signals were delayed, but clearly there was a signal. And the last one, RIPB. Yes, also delayed, but there were signals. And then after the first line, veins were isolated. After the roof line, then can we go to the next line? We just remapped during the professor's
Peter.
Yeah, Peter's
Professor.
presentation.
Professor.
Okay, let's move on to the last map. Okay, here we just made one line on the roof. Then after that, all signals on the posterior was gone, and we have to prove that the posterior box.
And if you can, Martin, if you can tilt it down, I really want to stress the density. You have some overlap maps because the line is not solid, so you please share. Okay, perfect. So you can see, so really what I said before, so I'm trying, this is the number 3 size, right?
Yes,
so the 6 millimeters estimate. So actually I really tried to get overlap of the these all lesions, okay? So to create really good overlap as we have experience with anti-NH and with Atul from the previous research, okay? So now Toshi is going for the Pentanav mapping on the posterior wall.
So can we paste on the posterior wall? Can we paste on the pentray?
And look, Peppo, we got the white tracing, so we have white egrams for you, okay? Is it visible? Peppo is visible?
It is visible.
Yes.
But
Okay,
you are
great.
basing from CS, not from posterior wall.
Okay. So, okay, so let's look at the Okay, so you know what, guys? I think we are isolated. So in principle, the patient is a sinus. So I really want to show in principle, the application. Okay, so what we can expect. So can we go just for some bonus lesions?
Yes.
Okay.
That's what I want to show.
Okay.
So, for example, rotate the map down a bit more.
Can you rotate tilt it down? Martin, listen to me. Martin, tilt down the cutter.
These two balls, I think that's quite okay, but just to be sure.
Let's make some extension or something, okay?
Right. So for this procedure, we need at least 5 gram contact or more. So just before you start application, we have to take a tag.
So we need to have a tag on the map arbitrary. So actually, I mean, our technicians
More
need
transparency
to tag it.
and tag, please.
Okay, tag it. Tag it some. You know what, Toshi? Give it some little bit better spot to make it better tag. Okay.
Okay.
Maybe better to use AP view than PA view if you're placing.
Yes, completely. Now it's better. Now it's better. Martin, go. Tag it. Perfect. Okay. Now we have tag it, and here's a pedal here. Actually, by pedal. And can you focus on the screen here? Zenko, can you get the camera and show the generator? Handy camera. Okay, please. Thank you. Okay, he's coming, and Toshi is stable, more or less. No,
it is stable.
It's
just
okay. So
respiration.
now this one, these two, no, go. This is more important. Okay. So now I will switch pedal, and I charge. Now it's charging the generator, and now it's application. Okay, so 22 amps, and now it's finished. Okay, so it's the pulse application. So actually it depends on charging, and then, I mean, what is heart rate? I mean, this is the length of application. If it's faster, the application is faster. Okay, so
and probably you noticed that catheter came back after we finished the application.
and actually, well, we didn't stress that too much. Okay, let's go for more for one more side, and I will apply, and you will see on the carto map that it's immediately disappear. Okay, tag it now. Thank you. Okay, tag. Okay, now I will switch on, and look at the carto. Okay, go to the carto. Handy on the carto. Okay, great. No catheters. Look, Pentanav is out and ablation catheter is out. Now, after finishing, it's going back. So it's a principle of a switching box. Okay.
Okay, so what is the plan? You have already box lesion, you have isolation of veins, so what is the plan to do?
I'm so sorry because our plan is finished. Okay, so we have no plans.
I think that's a good plan.
So Peter, can you hear me?
Okay.
Hello, Peter.
Okay, so can we move to the other labs?
Hello. Peter.
Do you have questions? Some questions, guys. You are not discussing.
I don't know if he's listening to me, but the last 3 rounds ablating.
Hiroshi?
Yeah.
I can hear you.
Okay.
Very good.
Okay, at least last 3 PFA application site, before the PFA application, already no potential. But Peter looking for the nice contact force, right, 20 gram, 30 gram, and ablate. And I try to connect it. So already potential is gone, but he's emphasizing you have to connect ablation lesion tags to prevent the conduction back, right? Like we discussing. Yeah. Elimination potential very easy, but after elimination potential, still you better to have lesion. But you don't have a contact force sensor. It's tough. We have no idea you're touching or touching too much. So they actually exactly we discussed there before lunch. that was Peter was doing. That's my understanding.
But
Thank you, Peter.
Hiroshi, I
Yeah.
think this is a very good point, and you discussed with me during AFib symposium, remember?
Yeah.
Well, we stressed the need of a contact force for really good application. So what we need to investigate more is if we can get with more contact force or more power, more force, better lesions, even with pulse field, okay? This is critical for us to understand. And
Thank
we
you, my
still
friend.
don't understand.
Okay. Any question?
No questions?
No question. I think we have to move to another place because we have two more we haven't
Okay.
yet.
Okay, thank you so
done.
much.
So thank you.
Peppo, don't forget to me like the galaxy. No galaxy. What I'm speaking. Cardium. Okay, globe. Okay, I have a pre-recorded case for you. Okay.
Okay. I'm
Okay,
not
thank you so much, everyone.
company employee. I don't care. Okay, thank you. Let's go to ICAM for ischemic VT ablation guided by
Okay, so
CT.
let's give this discussion.
Yeah.
Okay, you can start, Peter.
So,
Hello.
Hello, do
Hello.
you hear us?
Yes. Yeah, we do.
Hello.
Okay, so first let me welcome back again for another nice VT case. And let's, this will be imaging guided ablation with Frederic from Bordeaux. And we prepared a 52-year-old male with ischemic cardiomyopathy, again a large anterior aneurysm. He's got some episodes of the VT with shocks, but he has also some kind of slower VTs that were under the ICD detection rate, which has to be reprogrammed, and he had a syncope due to this. And he obviously was scheduled for ablation, and he has a large aneurysm and no thrombi, and he's on amiodarone already. He was not on anticoagulation therapy. This is his ECG, some extrasystoles, but also you can appreciate the scar on the anterior wall. And if you go to next slide, maybe we will see that. And this is the CT that was performed about 2 weeks ago or 3 weeks ago, and then was post-processed, analyzed in heart kind of server, and was sent back, and we incorporated to this procedure. So we can go move on, and this is one of his VTs. So there are multiple. This is one. Can we move on? This is from the ICD. You can see also the atrial channel. So this is definitely VT because there's a VA, a kind of conduction block or dissociation. There's less VAs than Vs. So this is the patient with large aneurysm, probably multiple VTs. Some of them slower, causing syncope. We are using general anesthesia. We are using transseptal approach to LV, and we are using intracardiac echo monitoring for blood pressure, and also decanaf for registration. And I will now turn over to Fred.
Did you induce at the beginning any arrhythmia just to see if there is inducibility of anything?
Yeah.
You
No,
just
so
go
we added
by-
during, so we'll come back. Can you hear me? Yeah, we'll come back on that. Maybe, can we have the full screen? You do have the full screen, or?
Of the cartel.
Yeah, just the cartomap. Okay. So first, as we discussed this morning, the merge is very important. So when we go when you go retroaortic, it's pretty easy. You take the aortic arch and it works pretty well. Going transeptal, we took the pulmonary artery bifurcation and coronary sinus, and then we went on the left side through transeptal, going at the apex, anterior, inferior wall, lateral, septal, just to make sure the merge was good. And then we identify those areas. So just to remind, the colors are wall thickness. So dark red being 1 millimeter, so the sinus port, going to 5 millimeter with a yellowish port. You see several potential isthmuses, but there is one in the middle. Maybe you can show us with the long one, which can fit with Sloveti on the carto. If you can show with the arrow on the carto, the middle one. No. I mean just the long in between, the long path in between the two. If you turn anterior, LAO. If you turn LAO, yeah, in the middle you have a long potential path. Yeah, exactly. So what the strategy was to connect this low voltage area, and you can show us what strategy.
So this is proposed by in heart. You're supposed to connect all these islands of the low thickness.
And once again, it's not just to follow that because this is drawn, and as I showed this morning, this is not the way it is in real practice. But the idea globally is to connect this area, and particularly when you have slow VT, the longest channel you can have in the middle, which is based on wall thickness heterogeneity. And then we started with that. Can you show us VisiTag? So once again, it's not just a straight line. We have a bit of hard time to not to capture when we start on the upper part, and so we had to do several points to make it non-capturable. Once again, the idea is it's very difficult by pacing to assure those blocks. So one surrogate is not being able to capture anymore in this area. And we did that, and then we had the first VT while we were doing that.
Can you show the first VT morphology?
It was
review screen on the Pruka.
It was spontaneous?
Yes, it was during the ablation, this VT originated. So can we see some signals? So morphology is more apical and about lateral, and we try to follow during the VT because it was 150. It was not that slow, not that fast, I would say. And then we terminated by mechanically. We were trying to get, but some of these. Can we see the termination, mechanical termination? So can we go slower? Just the sweet, so this was mechanical by extrasystole, but the premature beat is exactly the same morphology.
It's not exactly
and
the
when and there was a very good pace map at that point. So can we
show the
cardio? That was the violet color point on the line. I don't know whether you see the cardio now.
And where is it on the map?
Cardio?
Can you show it? Where is it on the map?
Just to give once they give you. So there's a violet color. Can we mark on the carto the violet color point? This was the site when we had then we had a reasonable pace maps. If you switch to the to the review screen, you would see a longer SQRS. And also, can you go a review screen for the audience, please? Just let me because we have to switch between these screens. So okay, so what you see on the right hand is the VT that was inducible. On the left hand, obviously, there's a pace map with a lot of longer SQRS, I believe, reasonable well. So obviously, we thought this might be a good site to ablate, and we, during sinus rhythm, ablated heavily there. And then we tried to, and obviously...
Sorry, how does it fit into your image before? Because you had to line somewhere else, and how does it fit your?
No, it was on the line. To be honest.
It's completely on the line. If you come back to the carto now.
Can we go back to the carto?
You see, it
was the violet color, which is on the end of the line. There was a reasonable pace map more to it. So there's a cluster of points to the left, to the more septal, to the violet color points when we ablated heavily. And obviously the point here is of this image guided, which is very fast because you don't really have to spend time of geometry creation. You just go in and just try to connect, but it saves some time initially, but obviously then you have to deal with what's left over after you finish these lines. And this was one of those VTs that we had to burn more than probably we thought in the initials, but it's still EP, but the imaging is nice for the initial part.
And the point, even if it's images, there is EP, and of course you have to block your part and make sure the lesions are effective. And this is why we try to capture afterwards to make sure you did something good and complete. So we had to complete that area. And then we try to reinduce.
So can we see VT2, which is very interesting, and I would ask the audience what they think about the VT2. If you go to a review screen.
It's more septal.
And maybe you see it, there's a particular thing about this VT. It's a very sharp and very rapid onset, and then very, very, very wide QRS. Exactly. Good so point. Unfortunately, we didn't really expect it, so we didn't have a his bundle recording. but we had a RV catheter, this decanav in the RV. Can we go inside and see the RV tracings from the decanav? And if you really follow, there is something which may resemble his. It doesn't look like an artifact. Hopefully you can see that. And there's another way how to verify that that might be a bundle branch except of the ECG morphology. And then I will try to demonstrate now. So if I put back the catheter to the RV and put it to the right bundle. So if you go online, screen, you can go online, Pruka.
Yeah, it's lovely.
So so I'm in the RV, and you see the right bundle recording. And now we will pace with the small amount of energy and to see whether we will resemble the morphology of the inducible VT2. So let's do it. Can we pace? So maybe more. Okay,
yeah,
now.
It is.
Yeah.
So we have a couple of captured beats. And now if you're on review screen, can you go to review screen for the audience and compare these two captured beats with the VT morphology of the VT2. Okay, so, and if you follow, it's not that different. I would say it's very much similar, especially the second beat. So I believe that's, for me, because of the morphology, because of this tiny signal with the RV catheter, which probably was something from the conduction system, because it was definitely pre-systolic, and also this pacing at the moderator band and the right bundle gives you an idea that this was very likely bundle branch reentry. Do you agree?
Yeah, I do, but
we try to reinduce that tachycardia.
It also nicely demonstrates that you have to know a little bit about EP, not just look at the images and do some connection of any images, you know. This is example that you have to know, you have to understand EP.
So it's always a mix, but it prevents complication. Yeah, of course, and that's very important. And once again, it's very important to pace, to see SQRS, to make sure you are in isthmus, these kind of things. But then you have more time to focus on that and not having 8 different morphologies chasing one VT to the other when it can start to get difficult and you get complication.
So the question is, because we have induced this VT2, which had a cycle length. I don't remember what was the cycle length, whether this was a clinical VT, but there was a sustained, it was quite rapid. So I believe because the QRS is not that wide, we probably can go for right bundle branch ablation, because it usually doesn't give the patient the detrimental effect on the, and it's very likely that that was a bundle branch reentry. So that's the plan for us right now, and then come back to the left ventricle and see what's left. We already once induced polymorphic VT, which was VF, so it was with 3 extra with a short coupling interval. That's obviously something that no imaging can cover so far. But the point of this imaging was to transect something to prevent the very slow VTs with the long channels. And we did some kind of lesion set which so far did that, and we had the inducible bundle branch reentry.
And that's really what you are saying, a combo. I mean, the point here is not to say that imaging will replace all. And of course, you need knowledge. And really a combo, it's per time and it's safe, not inducing 10 or I don't know how many different VTs and mapping every single VTs. And then you focus on what remains, and here bundle branch reentry VT, and it's a very nice example, of course, yes.
But it again emphasizes what I said in the morning, that it's probably not a good idea to make this ablation just because you have imaging in every small center with a low experience. So I think this is nice example of that.
Yeah.
Anyway,
so if I can show one last thing before you can move on, it's that if you can go for ICE image, I would like to show you something. Can you go ICE image on the large screen? Just for the people, just the correlation, because I really like ICE in terms of correlating these structures with anatomy. So maybe you need the big screen for the...
I'm showing it, yeah. This moderator
Okay,
band.
so what you see is the RV, and down there is the RV apex. I'm moving a little bit the catheter, but I'm trying to show you that the right bundle runs in this moderator band structure, which is a kind of cable that connects the septum, which you see on up. The catheter is on this cable, and then it connects to this kind of complex of the papillary muscle. And generally there where you can anatomically find the right bundle, and that's exactly where the actually signals we have. So that's just the point that it's nice to have something that these inner structures, so the right bundle doesn't really run, I would say, on the kind of outer surface. It's a cable that runs there. Obviously, you can search for it just using the electrograms, but this is just a nice correlation of the anatomy and electrophysiology.
Again, it's nice because you emphasize again online imaging is very important, as we discussed yesterday.
Yeah, it's combination.
Yeah, but online is the most important. Okay, we will move to Austin, and if you can do then the rest of the case and then show us the result, we will move to Austin now. Okay, thank you very much.
Sure.
Very nice examples. Andrea.
Thank you. Can you hear me, Joseph?
Yeah, excellent.
Good.
So it's your
So I'm here with
time now.
David Burker. Yeah. Sorry that we have a lot of, the patient just arrived last night with ICD shock. Some of the patients we plan to do, they could not make it for family schedule. So I don't have nice picture. We didn't have time to put together a nice picture of the history. So I'm going to tell you, this is a 68-year-old patient with ischemic cardiomyopathy, ejection fraction 25 to 30%. With also beside the MI history, angioplastic in the LAD in 2022, that has also diabetes and stage renal disease, and in fact his ICD is a subcutaneous ICD because he's on dialysis, so we try to avoid endovascular lead and risk of infection. And he presented despite antiarrhythmic therapy with amio with VT. They were shocked by his defibrillator was about 150 beats per minute. So as I mentioned in my presentation, I say our approach is sort of a homogenization. You see, I don't know if you see here, maybe we can show the endocardial map. There is it. And David is ablating with stereotaxis. We already have done the epicardial map, and we'll show you later. We actually had sort of much more delay, higher amplitude recording in the epicardium. The endocardium overall, yes, delay, but very low amplitude stuff, and that's where David is ablating right now. Yesterday we mentioned the issue with the induction and mapping approach, and one of the problems sometimes we have is that the patient is not inducible. This is the case. We actually pace the patient. We can show you some patient. We pace the patient from the scar to maximize chances of induction, and we only got about 2 or 3 beats. So we could not induce the tachycardia. But the approach anyway is driven by ablating the substrate, and we're going to do both endo and epicardial location.
But
any questions?
If I'm not wrong, this is a septal substrate. So how you can ablate epicardial?
Well, this is it's not septal. This is kind of a apical. Apical. If you see this is the map from below.
Okay. Can you give me RAO just to have an idea?
This is RAO. Yep.
Oh, this apical part.
Yes. Is apical. Yeah, it's an apical scar. Yes. It's an apical scar, and I can show you. Maybe we can show. Can we stop for a second, David, and show the epicardial? Let's go. Let's show the epicardial. So this is the epicardium. So if you see the scar much smaller because a lot of the recording actually have very large electron, but they're very delayed. So if we show the activation map, the isochron, let's show the isochron. Okay, there you rotate, so you can see. So that's Can you show the one that we did? Yeah, there's it. You can see at the bottom, yeah. That's it, the area with all the delay activation. So not necessarily low amplitude, but very delay recording. Maybe we can show some example, Natalie. Natalie is our Carto mapper. Okay, maybe there was some of the recording was very delay. Yeah, you can see that the recording, but there was even something more delayed than that. I remember it was like a really high amplitude.
Is there any coronary artery in that area? Or is it gone?
No. Yeah. Yeah, you can see some recording. We have stopped doing coronary angiography in the post-MI patient because we were ablating really the scar area. So we are not going to do a coronary angiogram in this case. We kind of presented many years ago an abstract showing that in this patient probably is not helpful to do that. Obviously, it's different if you're non-ischemic or normal heart.
Yeah,
normal heart VT.
I
That's
agree.
sort of different situation.
I agree.
Yeah.
I'm just asking for people here.
Yeah.
So the idea is to do this as apical ablation epicardial, contralateral?
Endocardial, we were doing the endocardial first, and then we want to kind of look at the, sometime it's kind of buried in our paper, but the Bordeaux group also reported the same. Sometime by ablating endocardial, you sort of affect the epicardial recording. I think we see that more frequently in aneurysm, but we've seen in cases where there is no aneurysmatic dilatation. So we're going to ablate endocardial first, and then we'll go back epicardial and eliminate the delay potential in the same area.
So you will remap after ablation endocardially?
Mm-hmm. Yes, yeah,
okay.
Yeah. And the endpoint, so they're all at least 40 watts lesion for about a minute. The endpoint is really losing capture. We pace from the scar before, try to induce, and as I mentioned, we couldn't induce sustained VT. But the endpoint endocardially is to achieve lack of capture in the area that we ablate.
What kind of output do you use for this capture?
We start at 40 watts and go up, but at least 40 watts minimum. Remember, this is a stereotaxis.
For pacing.
Oh, for capture, we go up to 10.
Oh, okay.
Yeah.
So you are continuing now ablating endocardial?
Yes, we can continue to ablate endocardial, and then maybe we'll touch base once we go back epicardially. I think the endocardial part is almost done.
Is there any question now for operators or about strategy? Can we, Andrea, move to another hospital and come back in
go
15 minutes or so?
We'll touch her. Yes, absolutely.
Okay,
absolutely.
Perfect. Thank you very much so far.
Bye.
Thanks, bye. So we are back in Homolka for this first case. We started to see with Jose Merino.
Yeah, live.
So Jose, how did you proceed?
Yeah, can you go back to the activation first, the first map of activation, if you remember it? Can you show us the activation map of the first flutter?
Ten první flutter. First flutter showing the color.
Okay, if you remember, we had this map that was not clear where this was a perimetral lateral flutter.
Yes.
It was not very convincing, but okay, keep going. Okay, so there was doubts whether it was rotating around the right pulmonary veins, and it was not really clear, for me at least. So what we did is a PPI map. Can you show us? Yeah. So in this map, white means PPI matching the flatter second length. Okay. And you see, and then you have the pink is +10, red means +20, and so on. So purple means quite long PPI. So rotate them up so they can see. Go to posterior wall, yeah. You see that there we have blue, some blue areas. That means that they are quite long. Go to inferior. No, inferior. Here you see that even the inferior wall was quite long, and the septal wall, you go to the septal, is quite long, PPI. So this was not a perimetral flutter, and it was neither a right pulmonary vein flutter. And the PPI was more concentrated in the anterior wall and in front of the left atrial appendage. Can you move it to show then? Yeah, that area. Okay, so there it looked quite strengthening. We mapped this with the grid, and nothing was found apart from this yellow dot. Can you show them the recordings in yellow dot? The signals.
The signals now, Pruka?
In the Pruka.
Ukažte Pruku.
No, but this is the last one, so we need to go.
Pane Pruku, jen tam, no, všechno ukažte, to je nejlepší. No. Tohle je dobrý. Review, okay, so now.
Okay, no, but it was there? No, I think it was in another, I don't know. No, I don't think that this was the signal. I think it was, you need to go a little bit before in the.
Can you show us this signal from the yellow dot?
From the yellow dot, je to tam nahoře, to tam bylo.
Can you go a little bit before?
Filipe, nahoře to bylo někde, dál, tam to mělo označení.
Before ablation.
Před ablací, no. To je.
Can you go back? Yeah.
Before ablation.
No, before.
Ne, before ablation, to je ještě potom.
This is it?
Tady, fragmented signal, tady, pojď nahoru.
Okay. Can you go down a little bit?
Fragmented signal, těsně před ablací. No to
there.
This one.
There. So you see the fragmentation there?
So this fragmentation is from the HD grid.
So it is HD grid at this area?
The best signal that we were able to get. So we decided to ablate there. That is still close to the good PPI area. And also, if you go back to activation map, it was where the exit site appeared to be, that it was the red. So there we performed a first application that did nothing, and a second, a third that did nothing as well, and the third one
before ablation.
Can you show us? Can you show us the termination of flutter, or the chain of the flutter?
Before ablation signal here.
No, but this is after. But this is
just běž před ten entrainment ještě kousek. Před to. Ne jenom popojit.
So where is this entrainment? Where is this entrainment done?
Or the last application, can you show them the signals? Okay, but never mind. Okay, there. Okay, so we started ablating there. Keep going, and the flutter changes suddenly from 360 second length to 380. The CS had a subtle change, but to be honest, quite subtle. So from 360. And then what we did is validate if the flutter just went a little bit slower, but remained in the same circuit or not. But then we performed entrainment, and you see that from the initial areas, that is where the catheter is located now, the post-pacing interval was quite long now.
Yes.
Initially it was matching the flutter cycle length, but then after this sudden increase in cycle length, the PPI significantly increased, and this was reproducible. So
and also activation sequence is different.
Yeah, last entrainment changed the CS activation sequence. Unfortunately, tachycardia changed by entrainment.
So
I think they changed during ablation, no?
No, I don't
Yeah,
think so.
it changed during ablation, so there was a
during
sudden
ablation.
change.
But there is a change in
What we do
activation
some of these
sequence
cases-
clearly here during.
In some of these cases, is what we do is to have a multipolar catheter. Rather than having a degree and the ablation, having a multipolar catheter in the left atrium and exchange the grid and the ablation catheter. So then you have a sequence of electron, so it's easier to realize when flutter change to another mechanism. Because otherwise you don't know if it's slowing down on the same circuit or it's a change to another one. So can you go to the new map, please? So we have performed a new map of this. Can you remove the transparency to make it more clear? And you see now the colors are quite different. So can you rotate it? Can you rotate the map? So go cranial view, yeah. So the red area that was in the anterior wall is slightly changed, and there was a descending front there. So it appears that it has changed to a circuit that is exiting more posteriorly. If you go, we don't have a PPI map here, but we have entrained from the lateral wall. Can you go to the lateral wall where this yellow dot is located? Can you show them there the electrons and the post-spacing interval? In that area, the post-spacing interval initially in the former flutter was long, not much, but it was plus 60
To je ta reference, to
something
ne
like that.
ten z ablačního, ten yellow. Ne,
No,
zase
this
jiný,
is this. No.
It's pretty long.
No.
And again,
No,
change in
this
activation
is-
sequence.
You have to go down. You have to go down. Go down. More.
Ukaž ten normální
Go-
pospacing, co jsme měli tady. Vole.
Go down. Go down. No, you have to go down. More. It's almost at the end. No, it's after ablation at the end.
At the end after ablation, there is not
But
note anymore.
more. No, it's further. It's further below. No, you need to go down.
This is the end.
Yeah.
Okay, so
We can
Okay.
paste simply from the yellow
so
again.
what is the plan now?
You can paste from there.
We are a little bit lost.
Yeah, no, the idea is that now we have a different
You can
circuit.
simply paste from
And
there.
apparently this red, this yellow dot is where, can you go back to 8-degree recording? So I place the 8-degree there. You see that there is some fragmentation.
Okay.
Can you enlarge the area and how it, yeah. Here. Wow. It's jumping, yeah. Yeah, it's jumping now. But apparently the circuit is now slightly posterior. We were about to start ablating there before you connect it. There you see that there are some fragmentation there, you see? Yeah.
So which one we need?
Can you paste from B34, please? No, you are not capturing. You need to increase your...
O 10 rychlejc ještě.
There?
No. It's not touching too much.
There. Stop.
Okay.
Yeah, so it's roughly
Double
plus
click.
20, so we are
Double
quite
click
close.
and-
So the idea
double
will
click,
be to
double
start.
click,
But
double click
we
there.
perform another site that was just in the exit side, and the PPI was matching more or less the flutter cycle length. So the idea is that this new circuit is something related to this rich area, maybe the vein of Marshall or something like that.
I would say that that's probably going epicardially to that area.
Yeah.
So what will you do with this? You will do mitral isthmus block or?
No, we will just ablate in this rich area, especially where this fragmentation was, and see if something happens. Otherwise, ablating the isthmus, I don't know if it's going to work, because all of you know how tough is sometimes, and you need to ablate within the CS. And I am not convinced that this is the problem. Maybe it's a case for vein of Marshall alcohol infusion, okay? But let's try it here and see if something happens.
So you will start ablation here.
Yeah.
We can even train from here if you like, or maybe.
Yeah, we can try it here.
It would be dangerous now, because you would isolate
No,
appendage.
don't pace, don't pace.
Yeah.
There is a comment, if you ablate here and you achieve block, then there might be appendage isolation, because there was initially a line anteriorly and you ablated also anteriorly more.
Actually, in this side, the original activation map showing some focal breakthrough. Can you go back the original activation map for the?
Sorry again.
Show us the activation map fast tachycardia.
Of the previous one.
First one.
Yeah. And then we have the some focal breakthrough in that region.
The appendage will be isolated. It's something that you always need to be
in the
careful
appendage.
About,
stay here. This could be showing the like a small macro reentry outside of left atrial appendage septary, red, orange, yellow, green, and then this mapia. Maybe it's going to the epicardial component and coming back red area. But if you go to left lateral, like left lateral.
Yeah, the idea.
Could you show?
Here. Component.
You see the orange yellow, more focal breakthrough. That could be somehow, may not be related to this tachycardia, but somehow epicardial conduction, endocardial breakthrough. Now you're targeting in this region. So they're like a double tachycardia, one tachycardia, originally shorter cycle length, small macro reentry outside left appendage. At the same time, something endocardial breakthrough at the appendage, like for the Joseph's showing some epicardial conduction through the Marshall tract. It's not surprising, but can you go ablation catheter in the orange area? There. You have arrow. Can you show the potential over there?
Yeah. I will do it now, but can you change to PPI map in this? So we paste there, and you see that there was orange, so it was not really good PPIs. It's true that we have not many of them, but we do it reproducibly.
But this is PPI map from the first tachycardia.
Yeah. The second one could be quite different. So go back to activation map of the second one. So here is where we have this kind of fragmentation. You see that still there is some red, orange, and yellow. So it's something that apparently is coming from there, and it's moving away from yellow to green, cyan, and so on. So maybe we can start here. Maybe if nothing happens, try to ablate the orange area of the first map, and if not, go to the exit site in the anterior wall, in the septal aspect of the left atrial appendage.
Okay, can we go to other lab to conclude the case and come back, or how you feel about that? Or you want to show something? You believe that you terminate now?
It's slowing down a little bit.
It's slowing down now. And termination.
Okay, I didn't do anything. Yeah.
Okay. So we isolated the right and the left veins, both first pass isolation. We made a remap. Maybe Sophie, you can quickly show it. So we made a voltage map of the left atrium and the right atrium. We had both first pass isolation. We saw that after the isolation of the veins, the extras, they disappeared completely. We don't know if it was because of the isolation of the veins or because the heart rate went up with 15 beats a minute in this highly sportive patient. He's a triathlete. We then mapped the typical flutter, the activation. We have the entire cycle length around the valve, and we were now waiting for you to start ablating here. Okay. So can you use again?
So you will do CTI line?
Yes, we will do CTI. We don't have the extras anymore. They completely disappear.
Yeah, that's my understanding. Yeah. So we have also ice. You can see they are ablating at the level of tricuspid valve.
There's something with the...
And here, what is set up here? I see 50 watts.
50 watts. Ablation index of 550.
Wow.
Pace.
So in the middle of the isthmus, he was in the middle.
Can you pace, please? Okay.
So there is not yet block.
Can you measure it? No, to the right. Why you display these microelectrodes if you are not looking at it? It makes a big mess in this recording. At least for me. You can hide them if you want. Yeah.
Well, the proximal is still earlier than this, so it looks that it's somewhere close to the ridge.
We do use them.
Slipped.
So there we drop off.
It's a bit prominent. It can be pressed down.
What are you saying, Sophie? How much is it? Okay, base ablation. Measure to the CS. No, pace at the same speed. Okay.
Spacing lateral now from
So I
the
think it's
line.
bidirectional block.
Under 34.
Pace one more the CS. Okay, measure once more, but we have nice doubles as well on transismus. You can also measure if you want. So I think we are done here. So maybe stop pacing to see if the extras are still there.
Can we see a running
So they completely
screen?
disappeared. Are there some more questions?
I mean, we don't see a running screen. Can you show us the other screen with
Can
signals?
you show the running screen, please?
Ongoings.
The live screen.
Yeah. Okay. So you paste now from CS.
No, we don't pace at all to show that the extras, they completely disappeared.
Yeah.
You want to pace from CS now, or what do you?
Oh, it's okay. So there are no ectopic beats.
No, I think we are done here. We have
You
the
have
first
block.
pass isolation, we have bidirectional block on the CTI, and we don't have the extras anymore.
Okay. Any questions from the audience? No? So it doesn't seem to be the case. So we have still some ongoing study in other place. So if you don't mind, we can go to Austin and we will finish this case, okay?
Okay, perfect. Thank you very much.
Thank you very much. It was
Bye-bye.
nice demonstration.
So, Joseph, David is done with the endocardial, is now going back epicardially, and was trying to get to the area of interest. So maybe we can show the endocardial map ablation. There you go, yeah.
Carpet bombing.
Those are, yes. Elimination of all the abnormal recording. And, but consider that, lesions are at least a minute long, and most of those dots are a single lesion just around the area. Yeah, but that's the objective. So it doesn't look like the epicardium has been most majorly affected by...
This is again activation map, is that right? Yeah. The epicardial is activation map.
No, this is the voltage. The activation is the one that you see on the other screen. If you, this one here, see? So that's a voltage, and because as I mentioned before, some of the electrons have high voltage, but they are very delayed, and the activation is the one you see with the isochron that you see here with this large apical red area.
Okay.
Do you see that?
Yeah. So you will ablate in this red area?
Yes. Yeah. You can see some of the recording. You have the recording. Yes, you see them. Okay, good.
How much energy you use for this epicardial?
Still 40. So I actually want to mention this. It's still 40. Usually in the epicardium, I prefer to use half normal saline. You know that with irrigation you can make superficial lesion. With half normal saline you tend to kind of improve the quality. Also, potentially have less sort of irritation, inflammation of the surrounding structure because of the ionic charge. The energy tend to go more to the tissue.
Andrea, hello?
Yes.
This is Hiroshi.
Yes. Hey, Hiroshi.
So epicardial ablation using stereotaxis, I think you know sometimes we try to aim the direction magnet toward the endocardially, right? If possible.
Yes. Yeah. This is actually one of the things that we feel that epicardially, although today with the flexible sheet might be less of a problem, but with the stereotaxis we feel we can get better contact because we direct the magnet towards the tissue. So, which is, Hiroshi was mentioned towards the endocardium. So, yes.
Thank you.
Certainly, that's a benefit. 100%. Okay. Let's check the ice sheet. I saw that, Joseph, many labs using ice, which is a nice thing. Even a group in France I saw using ice. Is that a shift or still not too much? Are you going to play? Yeah. Joseph. If we lost connection.
So in terms of the power application time epicardially, you're starting at 40 watts.
40 watts, yeah.
And usually like a 30 second, 40 second, or 60 second, or? At
least, yeah, that's the range, yes. But you see, that's the same area. So you see a lot of dots, but it's the same area ablation. So the lesion goes on a little longer.
Okay.
But so this is an example of what we discussed yesterday. That in this case we cannot prove that the induction because it was uninducible. Although we have some non-sustained stuff endocardially, but the reality is that even when the patient becomes non-inducible, you always have some epicardial substrate that is left over, and if the goal is really not to just prevent the clinical VT, but to get these people off antiarrhythmic drugs, you get best effect by being more comprehensive with the ablation of the scar, not just the endocardium, but also the epicardium. And I mentioned our experience even in the patient that eventually sent to radiation therapy because epicardial was not an option because of previous bypass surgery, and the surgical approach was considered too high risk because patients were sick. Even in those patients, we usually attempt at least 2 ablations in our center, and they all became non-inducible with the endocardial substrate. So even if the tissue is very thick, with the technology we have today, longer lesion, open irrigation, I think we have fed somewhat the epicardium to the point that patient become non-inducible, but it's not a permanent effect. In fact, all those patients eventually are recurrence. So if you follow, I don't know if you can see the recording on the, maybe we can enlarge that. I don't know if Matt is in the room. You can see that the delay potential is getting later and later and smaller as we ablate.
Andrea, can we
yes.
Can we finish case in other lab and come back
yes,
after
come back.
let's say 15 minutes just to close? Yes. Okay, thank you.
No problem.
Can we now go to ICAM? So we have this case by Frederic and Peter.
Okay.
Did you
so
perform this right bundle ablation?
VT3 and VT4.
Yeah.
So do you see us?
Yeah.
Hello.
Okay, you see us. So just where we left was the right bundle branch block ablation or the bundle branch tachycardia. So we started to ablate on the right bundle, and eventually we have a morphology of the. Can you show the QRSs now during the sinus rhythm? No, yeah, in the kind of online screen, maybe online screen. 12 lead, just 12 lead.
Yeah, that's it. Here you have the review, you can see.
Okay, so you have the right bundle. I believe that's not a big deal. You have bifascicular block. The PQ is not that terrible, and I believe we proved that concept of this tachycardia, so I believe it's fine. Then we induce, when we went back to the LV, we started to induce from the LV, from the opposite side of the scar, which we were not able to induce anything. Then we went back to try to induce from the right side, and we did induce VT number 3. Which was quite slow, which was this one, which originates. Can you keep it in the review?
The cartoon,
yeah. Now it's generally positive 2-3 AVF. It's quite basal, and it's negative in lead 1, and was 180 beats per minute. We start to map it, but eventually it's easy to terminate. Before the termination, we had a mid-diastolic potentials, mechanical termination. Can we show the electrograms? In the proximal, I don't know, maybe slow down, maybe that will be more apparent. And the slowdown, you see the proximal there was this one, and we terminated mechanically there. So we ablated, and maybe we also paste there just to verify that this part. You see there's a termination without, I would say, ectopies.
Can you show us on the map where was the site? Where was the site of termination and ablation?
Can we switch to Cardo?
Cardo. It was, can you see it? It's small there. Can you have Cardo full screen? Yeah.
Okay,
good.
so maybe you see up there, maybe somebody point you with the violet color point. So it's on the margin of the scar. We paste there. Can we show the review screen, the pace mapping? Can you show the review screen, the pace mapping there, which is the perfect pace map on VT3, Vojto? Can we show the review screen?
So it was really the one end of this
pace map. Yeah, so it's a long SQRS. Hopefully you can appreciate the morphology. I don't know whether you have the review 2 screen. I don't know whether it's not visible for you because of the other screen.
Yep.
Yeah, but the morphology is the same as the inducible VT. Okay, now maybe, okay, that's better.
Well,
and so that was there, so we ablated
reasonable.
Heavily there.
It's not exactly the same.
And we tried to reinduce, and obviously we have a VT4, which this time was kind of rapid and a bit changing morphology. It's slightly similar, but more, I would say, basal, because the V2 is positive. It's positive from V1 to V6, and also it's still the similar region. So the plan is to continue ablation a bit there.
Yeah.
Maybe you can comment.
Yeah. So the idea, if you turn a little, Carto, can you give the Carto back, please? It was more on the border there, and probably, and once again, what is important is making sure we are creating good lesion to block, and probably it was not completely blocked and exiting a bit higher up, so we had to do a more proximal or border zone application, and the other one is exiting a little bit more, as Peter say, a bit more lateral to that. So we'll keep going to this area to close it.
Can you show us RAO view, because this is now confusing a little bit. It's transparent. Okay, so it's yeah.
This is RAO, and maybe he will turn for you.
Yeah.
Okay, so keep rotating just to show. And this would be the more lateral. So there is still a lateral scar on the border zone that we didn't cover, so that would be our culprit. The upper part, somewhere there would be the target that we should extend the ablation and see what's left. Okay. But these are already rapid, a bit changing tachycardias. It's not those slow ones that we saw in the very beginning that we could ablate. And
again, and so that the point to just they are pre and after, and to extend depending on what you have, as we discussed at the beginning, with faster VT, a bit more unstable VT, more being on the border zone of this scar. Yes.
Okay.
Any comments, questions to this?
Is there any comment?
We can't hear you much.
Maybe we can again do one circle. We have still 2 labs working, so we can come back in few minutes.
Sure.
But then we have to finish probably around 4:30 because people want to have coffee also. You will have also coffee when you finish.
Thank you.
Yeah, but let's
go to Homolka again.
See.
Yeah.
Thank you so far. Jose.
The change was silent here.
They are saying that? I don't think so, because PPS were quite reproducible.
Jose, you look very relaxed. So you finished already, or how is it?
Yes, we finished, and just before or just after you disconnected, we apply RF here, and the tachycardia immediately stopped. You can see the program? Can you see the program? Can you see? Joseph, can you see the program?
Yes, we can.
So the ablation started there, and just 10 seconds after, tachycardia terminated. So then what we did is enlarge a little bit the lesion, going down to the this orange area of the first tachycardia, just in case, because here in the first tachycardia there was some fragmentation. So in order to be sure that this patient doesn't recur, because this was the 3rd procedure, we enlarge a little bit the lesion in this region. So what is the interpretation of the map of this last tachycardia? The initial one, it was clear that it was something going through here and exiting here. If I go back, this was the exit side, but this area were not really belonging to the circuit, and what belonged to the circuit was, if you look at the PPI map, is here. So probably there was some kind of epicardial short circuit, and this was the exit side. That is where this tachycardia was ablated. Yeah, and then we had the second one with a different map, as you see. Here the exit is a little bit more posterior. We had some fragmented electrons here. The PPIs were okay in this place, and is where we ablate. And afterwards, they have already showed. After that, what we did is paced. Can you see pacing?
No.
Can you see pacing?
Not yet.
Try to use the tachycardia, and we pace at different second length. So starting from 300, going to 350. Yeah. Can you go? No. Hold on for a second. Hold on for a second. It's better.
In 100?
Yes.
Okay. So the idea is that the second tachycardia was using epicardia, probably vein of Marshall.
I think so, because it's quite strange, and I think that we have done many cases so far, and this was one of the most strange that I has ever faced. And I think that maybe the reason is that because this was done with PFA, I don't know, we were discussing here whether you had a different type of lesion, more superficial, I don't know. And maybe you have some kind of epicardial breakthrough. But it's clear that it was a quite strange disposition of the circuit. After the case, what it was good is going down to 100. You can show them. Nothing was inducible, even a fib. So I think it was a combined job between Homolka and myself.
Great. Any question? Oh, we have mismatch here. Can you go back, because this is from ICAM, it's not from Homolka. Okay. No. Any question for Jose?
I want to ask about settings during the last applications. How many seconds and how many watts?
So what were settings for ablation in this area?
Yeah, to be honest, we have changed because, as you know, or maybe you know, but we have conducted a multi-center trial of high power short duration with 70 watts. This result will be presented during the ERA Congress, but we are now going back to standard settings, or the upper range of standard settings of 40 watts, and lesions guided by LSI. So we were aiming LSI of 6. This is our standard nowadays.
Okay. Any other question? If not, I think thank you very much. It was interesting. Even after pulse field ablation, you can still have some areas which might be quite difficult maybe to analyze, because you have very low amplitude of the signals around, so it might be quite difficult. So you could see some options. You can do PPI map. Whatever mapping system you use, you can do this map. So this is one option. But entrainment is very important in these cases, because you may be puzzled by signals if it's a low amplitude, and there is not much left in the atrium. So it was quite interesting.
Although the original activation map showing like a last ablation site endocardial breakthrough, suggesting some epicardial conduction marshal, and also septal side outside appendage showing a small macro reentry. It's not complete, but somehow suggesting. So he ablated there. So essentially, original activation map was useful.
Yeah, it was, but there is part was missing because it's epicardial, and this is very common in this area. Okay, Jose, thank you very much indeed, and to all people around.
Thank you.
So we can go to Austin again.
Yeah. So Joseph, we're done here. So you see the epicardial map with the ablation in the scar. And here you see the overlap in endo and epi. You see the distance between some of the epicardial lesion and the endocardial. Obviously, there is no way endocardially we're going to affect those. But closer to the apex, obviously, is where you can see some, closer distance, where those are the area where maybe we make the epicardial ablation easier. But so we're done in the area where we epicardially, where we ablated, we have no recording at all, not even a far field. And we tried to capture, there was no, we could not capture. David is at the table because he was removing the fluid from the ablation. And now,
and do you induce at the end of the procedure any tachycardia?
We can try, but at the beginning. Actually, I can show you what we saw. Can we go on show the induction where we had those 3 or 4 beats? We were actually pacing from the scar at the beginning. If you can see it on the map, right? Yeah, there it is. So you can see actually the same morphology of the area, which there is a long pacing to QRS, and we have like 2 or 3 beats with the same morphology. I think we have maybe one longer. It was a little faster, yeah. So that was from the endocardial scar. That's all we got.
Okay. So now you have complete modification endo-Epi.
Yes.
So you are happy.
Yeah.
You are happy with the result.
Yes. Yeah.
Good.
Yeah.
Any question for Andrea? Okay, it doesn't seem to be case. So I would like to thank you very much. It's a pity that you could not join us and do case here in Prague. You are also you participated several times in this workshop, so we would like to see you here for this anniversary. But I hope that next time we will have opportunity to meet again. Thanks a lot to you and to your team.
Thank you, Joseph, and thank you to everybody.
Okay, thanks.
Bye. Bye.
So final, we go to Ikem for last.
Relaxing.
Okay, so just conclude that we. Okay, hope you see us. We just still a bit struggling to get this anterolateral part with the transeptal approach, and but generally we believe we've done. At least 3 morphologies of these slower VTs were abolished. The bundle branch definitely was proved. That's another one, and we extensively modified the substrate. Can we see the ablation time, just to have a comparison for this large aneurysm for the previous cases? Můžeme on ablation monitor to see what's the total ablation time. So what I see now, the ablation time is close to the 1 hour. So because we were using lower power, we were not using 50 watts, but rather lower. So maybe that's, I believe, at one point in time we should stop with this. The ablation was extensive. We've induced last time some changing morphology. We went there, and maybe it's time to finish with this procedure. That's our approach, because the ablation is quite extensive right now. Any comments to this case? So it's image guided, but at the end, that's the beginning. Then it's still you have to chase the rest. It's still EP guided. And obviously, bundle branch is something that no imaging will show you.
So that's very important, that inducibility, because that's a very important point. Inducibility remains the only endpoint so far that has proven something.
A substantial modification of the substrate, elimination of the most, I would say, important parts of the circuit.
So we finished to reach.
We had this polymorphic VT, or the very rapid VT, was induced with aggressive triple extra beats.
There is a question from Piotr Kunakovsky. If you can show us the original image and then superimposed ablation points on the original image.
Okay. You have it? You have it there?
They want to show the initial
pace map.
You see these white dots, which they said, and then we extended more to the. We kept in the inferior part what was designed. If you tilt up, if you go tilt up, you may see that the ablation.
Can you make it less transparent? Can you make it less transparent?
And make it less transparent, the LV. That maybe you will lose some of the ablation points.
But the interesting point is, though, the VT were exiting from where we.
No, and the CT, not the 3D reconstruction.
And you see where we had the exit and the either mid-diastolic or good pace map were just exiting of this channel. So that's kind
correct.
Of interesting part. We had to extend, either because we couldn't get maybe transmural, or because there was other circuits not seen, especially for faster VT, as I said this morning. And yes, we are here. Can you pace map here? In this ablation,
Ablation can be pace map here, just to see the morphology. Okay, it's quite reasonable, actually. Can we see the morphology? Can you go review screen? So now we still, there's some things to do, and I had a problem. We change hands. It's good to have the possibility to change. There's still a slow conduction area, and maybe not the perfect for this, but it's still a kind of target. So we will still target this to extend it to the upper part of the scar.
And then we'll try to reinduce and see whether we have still something or not, and it will be
and
close
then,
to the end.
As they say, at the end of the day, it's the end of the day, so we will finish at one point in time.
It's a good end point. Well, thank you very much indeed for a nice demonstration. Thanks.
But there was an EP guided view that the bundle branch, I believe, was nicely demonstrated. So
maybe I have a question for you just before you leave. how many times you have bundle branch reentry VT. And this is important because even with any kind of substrate mapping, induction is at least interesting for that, just to rule out bundle branch reentry VT. And I think if you have 0 bundle branch reentry VT, is that you are not looking for it. So I don't know, can I ask the panel how often they find bundle branch reentry VT for scar-related VT ablation?
Was not that common, I think, but I believe that many of them are not recognized, and we certainly had cases that were transferred to us for epicardial mapping, and it was bundle branch reentry. So
the only
we had a general anesthesia,
bundle
and
branch.
we just did ablation of right bundle, and there
Yeah.
was nothing inducible, and so.
Yeah. That was my point. Yeah.
Okay.
Yeah,
Anyway,
you're
thank
right,
you very
and
much.
it's important
Again,
to
we
recognize
have
that.
some coffee break, and you
Stop.
can take also coffee now.
We'll try to reduce first, and we'll see after. Okay, can we go for?
Can you guys bring that in?